Hi, my name's Rachael Lucas and I'm an advanced care paramedic with Queensland Ambulance Service. Today I'm here to talk to you about external jugular venous cannulation. External jugular cannulation is the insertion of a catheter into the external jugular vein to facilitate the administration of fluids and medications. It is an invasive procedure that has more complications as opposed to a normal peripheral cannulation. The procedure in QAS is limited to one attempt per extrajugular vein. It's important to note in patients where EJ access appears to not be able to be obtained in a timely manner, or in a patient where it's not appropriate, intraosseous access is probably preferred. The BD Insight AutoGuard IV catheters are the catheters used in QAS, and they have a push button mechanism for safe retraction of the needle to prevent needle stick injuries. The manufacturer's instructions for use of the cannula line up perfectly with QAS, and therefore there's no considerations to be met. EJ cannulation is indicated when emergent IV access for the administration of medication or fluids is required and you've been unable to obtain peripheral access. The contraindications include agitated and uncooperative patients, purely because of safety, in terms of looking at the anatomy of where you're actually putting this cannula in, and anywhere where burns, infection or localised cellulitis is present, similar to that of a peripheral cannula. It's also important to note their preferred option is in particular injuries. If they're left-sided injuries, it is preferred to go with the right-sided external jugular and vice versa. The complications for EJ cannulation are very similar to a normal peripheral cannula, including drug and fluid extravasation into the tissue, hematoma or hemorrhage from site, infection or phlebitis, venous air embolus, and particularly arterial puncture. However, it is recommended for EJ access to enter the vein at a 10 to 20 degree angle. The external jugular vein is quite superficial compared to other anatomy, including the internal jugular and the carotid, and therefore arterial puncture, if you follow the technique correctly, is quite unlikely. Other limitations for this include patients that have C-spine injury due to the fact you're not able to get appropriate positioning of the head to get good access to the vein, as well as patients with obvious neck injuries such as penetrating trauma, etc. It's most important to talk the patient through the process, as it can be quite a daunting experience for them, having a cannula inserted into the neck and making sure you prepare your area well. We've got a bluey placed under the patient's head. We've got the patient's in Trendelenburg position to increase venous return and allow for optimum filling of the vein. And we've got our equipment set up at the side. So we've got our sharps container ready to put our sharps straight into. We've got an alcohol swab ready to clean the site. We've got our cannulas. In QAS, our CPG does state that you can use any cannula, but it's tips of the trade, anecdotal evidence suggests using only 16 or an 18 gauge for this particular vein. We've got our bung all prepared and ready. We've got a 10ml saline flush drawn up with a cap ready to be used, drug checked with your partner. And we've got an opside or tegaderm ready to secure the cannula once it's inserted. We've also got the Alaris two-way extension, which can be quite handy for these due to the fact it's quite difficult to give drugs through this with just the simple placement of the cannula. So using this facilitates that and makes it a bit easier. So to start off, we've got our head down. It also helps to prevent an air embolus. And without any risk of C-spine injury, we turn the head to a 45 to 60 degree angle to one side to get good visualisation of the vein. The external jugular vein runs over the posterior border of the sternocleidomastoid muscle. So to start off with, to prepare, we're going to increase our vein filling by creating a tourniquet effect by occluding above the vein, above the clavicle. We're then going to prepare our siphon aseptic technique, alco swab, and we're going to prepare our cannula, and for the purpose of this video I'm going to use an 18 gauge cannula. We're going to prepare the cannula by rotating the bevel 360 degrees and sitting it back in the notch to make sure it's prepared. We want to make sure we maintain traction of the skin, because obviously the superficial veins can move quite easily, and you are able to use a two-person technique that allows one person to maintain traction of the skin over the clavicle while you insert the cannula if required. So we're going to enter the vein. It's important to note tips of the trade anecdotal evidence suggests bending the cannula to allow you to stay very superficial and get that 10 to 20 degree angle. However, studies have actually shown that that increases the risk of cannula shear, which can be fatal. So I'm not recommending doing that, and I'm not going to be doing that in this video. The other thing to note is due to it's quite slow filling, you can actually, it's quite slow to obtain flashback, and so it's perfect once you think you're in the vein to just sit there and wait for your flashback. Alright, so to cannulate, we're going to enter the vein as superficial as possible, get flashback. We're then going to advance the cannula, occlude above the vein, retract the needle, and pop the bung into the cannula. Pop our sharps away immediately. We're then going to take our op site and just quickly put one tape over it so that we know we're not going to lose our access. And then we're going to follow it with flushing, a few mils of saline, and make sure we don't have any resistance on flushing. We're then going to secure the rest of the cannula using our op site. Obviously some surfaces may have different techniques for this, different applicators. Now, once that is in, we can start administering any drugs that are required in medications through that. It's important to monitor any fluid or drug extravasation into the tissues and to ensure patency. If for some reason you have a patient that's extremely diaphoretic, it's a good idea to apply extra tape, but make sure you do not apply circumferentially around the neck. Other concerns is just to really ensure that you don't have any development of a hematoma, and if you do, apply pressure and obtain other access rather than continuing to give drugs and medications through this. I hope you found this video helpful for external jugular cannulation. Thank you for watching.